Great. So here we are, an OB Practitioner's Guide to ACOG's new Neonatal Encephalopathy report. Dr. Waldman has an extensive resume, which I think you'll see in just a second, which includes, among the others, past president of the American College of Obstetricians and Gynecologists. And he certainly has had a huge commitment to ACOG in several positions. He was also the immediate past chairman of the OB-GYN department at St. Joseph's Hospital in Syracuse, New York, and was past medical director of performance improvement. Dr. Waldman has advocated for improvements in the health and welfare of women for the past 30 years, and in this arena he's established the first hospital-based midwifery practice in central New York. He's championed father-attended cesarean sections, the birthplace, VBACs, the New York State midwifery bill, and the right for women to directly access their OB-GYN. As a contributor to this consensus report, we are so fortunate to have him today to review the guidelines in this report, and as I mentioned, if time permits, to answer questions that will arise. Dr. Waldman, I'm going to turn it over to you.
Thank you, Peggy, and good afternoon, everybody. The report of the American College of Obstetricians and Gynecology Task Force on Neonatal Encephalopathy is the second report. The last one was published approximately 10 years ago. This report, as you can see, the members of the task force are before you, and it was quite an illustrious group of individuals. This was a very, very difficult task, and I'd say arduous, and working with some of the top people in the country. And I think the result is really rather excellent. Just a little bit of delay, but bear with me for a second in getting the slides to change. This document was jointly published by ACOG and the American Academy of Pediatrics and was blessed by 12 other major societies and had input in addition from the CDC and the National Institute of Health. The document should not be viewed as a body of rigid rules. The guidelines are general. They're intended to be adapted to many different situations, and they should be adapted for each individual hospital. And variations and innovations that improve the quality of patient care are to be encouraged rather than be restricted. There are multiple potential causal pathways that lead to cerebral palsy in term infants. And the signs and symptoms of neonatal encephalopathy may range from mild to severe. And instead of looking at this as one pathway with one particular way of development, serious brain damage in babies, we need to have a broader perspective, and that recognizes the fact that there are significant knowledge gaps that preclude a definitive or one test or 4 test markers that accurately identifies with high sensitivity and specificity an infant in whom neonatal encephalopathy is attributed to an acute intrapartum event. This is a very complicated topic. I tried to do the best I can to make it as easy as I can. And so we want to look at how likely an acute hypoxic ischemic event that occurred either in close temporal proximity to labor and delivery, in other words, just before the patient or a few days or a week before the patient came into labor, or intrapartum, what happened while the patient was in the hospital. And in order to do that, you have to have the correct case definition. You have to, the baby has to have developed an outcome that is spastic quadriplegic or dyskinetic cerebral palsy. There have to be neonatal signs consistent with an acute peripartum or intrapartum event, and the type and timing of the contributing factors that are consistent with an acute peripartum or intrapartum event. We're going to take those one at a time. To determine that the likelihood of a hypoxic ischemic event that occurred in labor or just before labor, it's recommended that a comprehensive, multi-dimensional assessment be performed of both the neonatal status and all the potential contributing factors, including history, obstetrical antecedents, intrapartum factors, including fetal heart rate monitoring results. And we're going to talk about all of those in this report today. This list is based on the premise that neonatal encephalopathy is due to acute hypoxic ischemia, will be accompanied by abnormal neonatal signs, will be associated with contributing events in labor or just before labor. So going first with the case definition. Neonatal encephalopathy is a clinical defined syndrome of disturbed neurological function in the earliest days of life in an infant born beyond 35 weeks gestation, managed by manifested by a subnormal level of consciousness or seizures, and often accompanied by difficulty with initiating and maintaining respiration and depression of tones and reflexes. The first mandatory step in any assessment of neonatal encephalopathy is to confirm whether a specific infant meets the case definition. And one of the challenges for the task force was no two studies have the same definition for neonatal encephalopathy. And that's a problem with the literature and interpreting the literature on this subject, which made it very difficult in some situations. Baby has to develop an outcome that's equivalent to spastic quadriplegia or dyskinetic cerebral palsy. Other types of cerebral palsy are less likely to be associated with intrapartum hypoxic ischemic events. And other developmental abnormalities may occur, but they're not specific to intrapartum hypoxia or ischemia in labor or just before labor. And they can come from a lot of other causes. So again, you have to have the right diagnosis in the neonatal nursery, and you have to have the right outcome in order to be looking to labor and delivery as a causal event. Now we're going to talk about the neonatal signs consistent with an acute peripartum or intrapartum event. Remember that the goal is to compile a constellation of markers concerning neonatal status, contributing events, developmental outcomes to determine if they're consistent with the diagnosis and may not be explained by other etiologies. Thus, the more of these conditions that are present, the more likely that asphyxia occurred during labor, and that was responsible for the outcome. The opposite is true. The less of these conditions that are present, the less likely that asphyxia was the cause of the neonatal encephalopathy. So these neonatal signs consistent with an acute peripartum or intrapartum event include an APGAR score of less than 5 at 5 minutes and 10 minutes, fetal umbilical artery acidemia, neuroimaging evidence of acute brain injury, and multi-system organ failure consistent with hypoxic ischemic encephalopathy. Well, we all know the APGAR score. The APGAR score of less than 5 at 5 minutes and 10 minutes. That's what we're going to discuss right now. So the APGAR score of less than 5 at 5 and 10 minutes clearly confers an increased relative risk of cerebral palsy, and the degree of APGAR abnormality at 5 minutes and 10 minutes correlates with the risk of cerebral palsy. However, just remember that most infants who have a low APGAR score will be normal and will not develop cerebral palsy. There are many potential causes for low APGAR scores. But if the APGAR score at 5 minutes is greater than or equal to 7, it's also unlikely that peripartum hypoxia ischemia played a major role in causing the neonatal encephalopathy. So an APGAR score greater than 7 is a really good marker that hypoxic event did not cause the issues with the newborn. Everybody remembers that the APGAR score is an expression of the infant's physiological condition at a certain point of time. It also has a limited time frame, and it's very subjective at times. And remember that a low 1-minute APGAR score is a very poor predictor of long-term neurological outcome. And the absolute risk of cerebral palsy remains very low, even in the setting of a low APGAR score. And that's the only finding score for infants undergoing resuscitation at birth should be recorded on an expanded APGAR score form. That form is included in the report, and I refer you to that. And so we want to keep much more detailed findings of the resuscitation and who was present at the resuscitation and the extent of the resuscitation. That's very important for the records and to have a complete evaluation. Now we're going to talk about the umbilical artery acidemia. If the umbilical artery pH is less than 7, or a base deficit is greater than or equal to 12, or both, that increases the probability that NE, if present, had an intrapartum hypoxic component. Lesser degrees of acidemia decrease that likelihood. If the cord arterial gas pH levels are above 7.2, it's unlikely that an intrapartum hypoxic event played a role in causing the neonatal encephalopathy. There is a continuum of increasing risk of NE with worsening acidemia. And it's important to remember that even in the presence of significant acidemia, again, most newborns will be neurologically normal. And the presence of metabolic acidemia does not define the timing of the onset of the hypoxic ischemic event. It cannot be used that way. The pH, the PO2, and the PCO2 values remain essentially unchanged for up to 60 minutes in clamped vessels, but change significantly in specimens obtained from the placenta via an unclamped vessel. In other words, vessels that are in continuity with the placental vessels. In specimens contained from clamped sections, the base XX goes down to a small degree in room air, but after 60 minutes it goes up considerably. And lactate measurements in the umbilical artery are not valuable with a delay in evaluation. Thus, effort should be made to doubly clamp the umbilical cord promptly after birth and obtain and analyze the sample expeditiously. If there's an expected delay, you might want to put the sample on ice because that might help with the base deficit and the pH. What's changed, one of the changes that's significant in this treatise is that neuroimaging evidence of acute brain injury seen on brain MRI or MR spectroscopy consistent with hypoxic ischemia is now a very important part of our evaluations. The MRI is the neuroimaging modality that best defines the nature and extent of cerebral injury neonatal encephalopathy. Distinct patterns of neuroimaging abnormalities are recognized in HI cerebral injury and have prognostic value for predicting later neurodevelopmental impairment. If the results of the MRI or MR spectroscopy are obtained after the first 24 hours of life, are interpreted by a trained neuroradiologist and no areas of injury are noted, then it is unlikely that significant peripartum or intrapartum HE brain injury was a significant factor in a neonatal encephalopathy. Early MRI obtained between 24 hours and 96 hours of life are more sensitive for the delineation of the timing of the perinatal cerebral injury, whereas an MRI undertaken optimally 10 days of life within a window between 7 and 21 days will best delineate the full extent of the cerebral injury. So for timing, you want the one that's before 24 to 96 hours, and for extent of the injury, you want it hopefully around the 10th day of life. The MRI has several well-defined patterns of brain injury associated with neonatal encephalopathy and cerebral palsy. They're the basal ganglia thalamus pattern, the watershed or border zone predominant pattern. If there's a different pattern of brain injury or evolution of injury exists on the MRI, then alternative diagnosis should be actively pursued. There are certain patterns of brain injury seen on MRI that are such as focal arterial infarction. I won't go through the list. I really wouldn't be able to identify them. But they suggest that peripartum hypoxic ischemia did not play a role in causing NE. 20% of the infants born at term with severe hypoxic ischemic encephalopathy cannot be safely transported to the MRI scanning suite. And few centers have experience in routinely imaging critically ill infants, making an intimidating proposition for less experienced centers. And one of the considerations or suggestions is that MRIs be added to full-service neonatal intensive care units in the future or near future, so that the babies do not have to be transferred in order to get the MRI imaging. Cranial ultrasound, which is something that we've used in the past, lacks sensitivity for the common forms of brain injury in the encephalopathic newborn. The ultrasound will help in the first 2 to 3 days of life with identifying major cerebral dysgenesis and antenatal lesions, and for instance, can tell you if the cerebellum is there or not there. It's an easy technique, and that's why it's been used so easily, because it really doesn't require any transportation of the baby, and the interpretation is a little easier than the MRI. And it may be the only imaging modality that's able to be obtained in a very unstable infant. The CT, computed tomography, however, lacks sensitivity for brain injury in the newborn and will often not reveal abnormalities in the first 24 to 48 hours after an injury. Has the advantage of being a fast or rapidly acquired neuroimaging technique, but and it does have a sensitivity for identifying hemorrhage. But CT scanning in the newborn is also associated with an increased risk of cancer and an increased risk of later cognitive impairments. So really, they're moving away from CT. Presence of multi-system organ failure consistent with HI encephalopathy is our last piece of this neonatal signs consistent with an acute peripartum or intrapartum event. So the multi-system organ failure can include, which everybody knows by now, kidney failure, hepatic failure, hematologic abnormalities, cardiac function, metabolic derangements, GI injuries, or a combination of any of the above. The presence of organ dysfunction increases the risk of HI encephalopathy in the setting of NE, but the severity of brain injury seen on neuroimaging does not always correlate with the degree of injury to other organ systems. The type and timing of contributing factors that are consistent with an acute peripartum event are also important. And in this setting, you need a sentinel hypoxic or ischemic event that occurred immediately before or during labor. Fetal heart monitor patterns consistent with an acute peripartum or intrapartum event. Timing and type of brain injury patterns based on imaging studies, and no evidence of other proximal or distal factors that could be contributing factors. So what would be a sentinel hypoxic or ischemic event occurring immediately before labor and delivery? Well, the examples I've given here, classic ruptured uterus or severe ruptured placenta or umbilical cord prolapse. Fetal heart monitoring, we're going to talk a little bit about. Category 1 or 2 fetal heart rate tracing, when associated with an APGAR score of 7 or higher at 5 minutes, and a normal umbilical cord artery blood within 1 standard deviation, or both, is not consistent with HI event. Is not consistent with an HI event. There is a great distinction that has to be made between a patient who initially presents with an abnormal fetal heart rate pattern and one who develops an abnormal fetal heart rate pattern during labor. So there are a couple of things that are important about that. The baby who shows up and has an abnormal fetal heart rate on labor may be ill if there's an intervention such as immediate cesarean section, but that problem did not occur during the labor. However, if you have an abnormal tracing when the baby first comes into the hospital, and then the baby is subjected to an extensive induction with that abnormal pattern 1-2 fetal heart rate pattern lasting 60 minutes or more that's identified on the initial presentation with persistently minimal or absent variability and lacking accelerations, even in the absence of decelerations, is suggestive of a previously compromised infant. If fetal well-being cannot be established, then deliver that baby and you may not get a change in the outcomes, but you won't be making the baby worse by not subjecting the baby to labor. A patient who presents with a Category 1 fetal heart rate pattern that converts to a Category 3 is suggestive of a hypoxic ischemic event. The other things to be looking for, which may suggest intrapartum timing of the hypoxic ischemic event, include tachycardia with recurrent decelerations and persistent minimal variability with recurrent decelerations. Just as a reminder, there's no evidence demonstrating that electronic fetal heart monitoring reduces the rate of NE. And when compared with intermittent auscultation, the major studies that were done a number of years ago shows that electronic fetal heart rate monitoring does reduce the rate of neonatal seizures, but does not reduce the rate of stillbirths. In labor, induction, or augmentation, or both, a decrease in the oxytocin dose should be considered if tachysystole occurs in the presence of Category 1 tracing, and if there is a Category 2 or Category 3 tracing, oxytocin should be reduced or stopped, and intrauterine resuscitation techniques should be initiated. As a reminder, the tachysystole is defined as more than 5 contractions in a 10-minute window, but really that's more than 15 contractions in a 30-minute window. So fetal monitoring becomes very, very important with using the new classifications and being able to respond to tachysystole and being aware of the type 1 and 2 and type 3 fetal heart monitoring tracings. There's no evidence in the current literature to support the ability of a practitioner to predict neonatal injury or cerebral palsy or stillbirth using electronic fetal monitoring. And this is yet still the only major tool that we have. Timing and type of brain injury patterns based on imaging studies consistent with the etiology of an acute peripartum or intrapartum event. MRI and MR spectroscopy are the most sensitive neuroimaging modalities to assist with the timing. And then again, we talked about it, between 24 and 96 hours provides the most useful guide on the potential timing of a cerebral insult. 2 scans, or magnetic scans with spectroscopy scans, first between 24 and 96 hours of life, with emphasis on evaluation of diffusion and spectroscopic abnormalities to assist in clinical management and evaluation of the timing of the cerebral injury, and a second at day 10 of life, will assist with the full delineation of the nature and the extent of the cerebral injury. Information regarding the timing is best obtained with the early and the total amount of damage at the 10-day. It's important to emphasize that despite the advances in neuroimaging, the ability to precisely time the occurrence, estimating within days rather than hours, of a hypoxic ischemic event is still quite limited, and that magnetic resonance imaging studies have defined that the vast majority of cases of cerebral palsy injury are seen in newborn infants with neonatal encephalopathy or acute. However, our epidemiological studies have suggested that 70% of the causation is related to the chronic antenatal factors. The apparent contradiction between the epidemiological studies and the MRI studies relate to the imaging findings that are in the first 2 to 3 weeks of life, and they demonstrate a subacute pattern. These studies cannot, however, delineate if the injury occurred during labor or within the days before labor. Clinicians should recall that fetal stillbirth rates in the 3rd trimester remain higher than neonatal encephalopathy by a factor of 3. There are 3 times as many stillbirths as there are babies that develop neonatal encephalopathy, indicating that an injury and death can occur outside the setting of labor. Thus, research into the timing of cerebral injury remains critical to our understanding of the pathway to neonatal encephalopathy. MRIs are showing that there is more damage done in during or just before labor starts and during labor than we thought before. But the precise timing of that injury really cannot be delineated at this time. Accurate interpretation of imaging is important, and we need ongoing education in interpretation and reporting of neonatal neuroimaging. We have very few pediatric MRI neuroimaging availability, and there is limited expertise in pediatric or neonatal neuroradiology, and the inconsistencies are really significant. In other words, there's a great deal of variation in both the quality of the MRIs and the ability for people to interpret them. And we need to have much more education in this area and many more people who are trained to interpret the MRIs. There's no evidence of other proximal or distal factors that could be contributing factors. By that I mean in the presence of other significant risk factors such as intrauterine growth restriction, maternal infections, fetal maternal hemorrhage, neonatal sepsis, chronic placental lesions, a subacute intrapartum event as the sole underlying pathogenesis of neonatal encephalopathy becomes much less likely. But just like the baby that comes in with an abnormal fetal heart monitoring during the first part of the introduction to labor, that occurred before labor. And so as babies with abnormal growth or maternal infection, those problems can occur before the baby ever got to labor and delivery. We also have other advances that occurred in the last 10 years. I'm going to talk about the placenta a bit, but we're not going to talk about genetics. It's just too much in this particular presentation. So I'm going to suggest that you read up on the genetic susceptibility to NE because we have new and emerging facts, but we are still investigating the placenta and genetic susceptibility to NE. The placenta obviously provides essential information about the pregnancy and fetus that's available from no other source. And before I go any further, I just want to make the plea for placental pathology being used more often, and especially in the babies that have neonatal encephalopathy. Adequate placental function is critical for fetal development and survival, and inadequacy of transport or nutrition through the placenta can lead to IUGR, which is strongly correlated with neurological compromise. A guideline for the indications for placental examination has been developed by consensus experts, but the placenta is examined in fewer than 1/2 of all deliveries in which the placenta fulfills those indications for examination. And although the placentas of all infants with neonatal encephalopathy meet the criteria for examination, only 11% of placentas were examined in one series. In another study, only 24% of babies who develop cerebral palsy have been examined. So there again, my plea, do not be a placenta dumper. Some of the placental factors, such as decidual vasculopathy, is found with fetal growth restriction, and fetal growth restriction is associated with neonatal encephalopathy. Placental infarcts are identified in a substantial percentage of clinically uncomplicated pregnancies, but the infarcts in the placenta are increased in babies with cerebral palsy. Retroplacental hematomas or leading to significant rupture of placenta are associated with intrauterine demise and neonatal encephalopathy. This condition, which is perivillous fibrin deposition, is very rare, but it has a high association with fetal growth restriction and neonatal encephalopathy. Cases with maternal floor infarction have lower developmental scores in all areas tested, and more often have neurological or developmental impairment. Umbilical cords that are abnormally short or long are associated with amniotic fluid buy-in problems, abnormal fetal neuromuscular activity, and acute intrapartum events such as abruptio. Abnormal cord length is not associated with umbilical acidosis at birth, and short cords may be associated with increased incidence of abnormal neurological outcomes beyond 4 years of age, and if other factors such as a low APGAR score or low growth and birth weight are present. So it becomes not been directly linked to postnatal neurological outcomes. Despite significant evidence relating to umbilical vein varicosity, the rates of fetal and neonatal death, no studies have linked umbilical vein varix to neonatal encephalopathy or cerebral palsy. This umbilical cord stricture is a major contributor to intrauterine device, but there's no established link with cerebral palsy. Hypocoiling or flattening of the umbilical cord may correlate with an increased risk of preterm birth, but at present there's no association with abnormal umbilical cord coiling and perinatal neurological injury. Fetal thrombotic vascularity, on the other hand, is associated with obstructive lesions of the cord, including cord hypercooling and hypocoiling, filamentous cord insertion, true knots, nuchal cords, and umbilical cords with increased vorticelli is highly associated with neonatal encephalopathy and cerebral palsy. Nuchal cord is common, but the vast majority of term deliveries with nuchal cords have normal outcomes, and a large population-based study found no association of true knots in the cords with cerebral palsy. The other change that has occurred, which is really rather significant, is that the standard of care is now to cool babies who develop neonatal encephalopathy. The use of hypothermia is a milestone treatment. This is a recognition that this therapy improves early childhood outcomes, has accelerated the pace of investigations, and given us hope that there are other brain-oriented treatments out there. Remember that more than 40% of the newborns undergoing hypothermia treatments still develop adverse neurological outcomes, so it doesn't work for all babies. And what the treatment does is it cools the baby from the normal 98.6 to 92.3 for a 72-hour period. The criteria for admission for whole body cooling baby must be 36 weeks admitted to the neonatal nursery at less than 6 hours of age, with either poor respiratory effort at birth and a need for resuscitation, or the diagnosis of encephalopathy. pH has to be 7.0 or less, or a base deficit of 16 or greater in the umbilical cord artery within 1 hour or within 1 hour of birth. There has to be some acute perinatal event, late or variable decelerations. I've got a list here that you can look at later, and either a 10-minute APGAR score of 5 or less, or assisted ventilation initiated at birth and continued for at least 10 minutes. There has to be evidence of seizures or neonatal encephalopathy by standard neurological examination. The babies that cannot have full cooling would be those who are not under 6 hours of age, those with a major congenital abnormality, those that develop severe growth restriction, birth weight is 1,800 grams or less, or obviously if there's a refusal of consent by a parent or attending neonatologist, or you have a moribund infant for whom no further aggressive treatment is planned. Meta-analysis of RCTs with outcomes of at least 18 months of age confirmed that prolonged mild cooling, whether either provided by a cooling cap or by systematic cooling, reduced the rate of death and of severe disability and increased the rate of intact survival at 18 to 24 months of age, and that the only problem with safety was a low platelet count occurring more frequently in the cooled infants. The more severe the hypoxic ischemia, the shorter the therapeutic window. Hypothermia extends the window when other pharmacological therapies may be effective. It's critical that hypothermia be started early in the latent phase before the start of the secondary deterioration, seizures or secondary energy failure, for it to be effective. Hypothermia favors and modulates nearly every metabolic outcome: metabolic, molecular, cellular events, and cell death in the acute, subacute, and chronic phases of HI. The success of treatment with modern cooling has shown that neural rescue therapy for neonatal encephalopathy is achievable. So we still have a lot of work to do, however, because we still have 40 to 50% of the babies that still have adverse neonatal events. One of the strongest antepartum risk factors for neonatal encephalopathy was fetal growth restriction. The risk of neonatal encephalopathy also increased with each each advancing week of gestation after 39 weeks. Elective cesarean delivery before labor, primarily because babies without a previous cesarean delivery, has significantly reduced risk of neonatal encephalopathy. Extensive evidence supports a strong relationship between IUGR and neonatal encephalopathy. The odds ratio of having a baby who is in less than the 3rd percentile of developing neonatal encephalopathy, it occurs 38.2 times more frequently. The odds ratio between the 3rd percentile and the 9th percentile, the odds it's 4.4. So those babies are 4.4 times more likely to develop neonatal encephalopathy, and this carries over into cerebral palsy because the cerebral palsy rate is strongly associated with birth weight less than the 3rd percentile, and the cerebral palsy rate is 6.4 times more frequent. And the more severe the fetal growth restriction is associated more strongly with downstream neurological disorders. What that means to me is that if you have a baby with IUGR in labor, you want to watch that baby very carefully and intervene at the first sign of trouble. And if the baby is less than the 3rd percentile, consider immediate intervention and not allowing the baby to go into labor. Infection is not the most common cause of increased maternal temperature during labor, but the use of epidurals is. And there is evidence that pyrexia during labor increases the risk of neonatal encephalopathy. Of the women with fever, 23% had neonates with a 1-minute APGAR score less than 7. And comparatively, only 8% of women without fever had neonates with a 1-minute APGAR score of less than 7. It seems that when the mother has a fever in labor, the babies are less able, sort of like the opposite of cooling, the babies are less able to tolerate problems during their labor. Antenatal intrauterine infection is a risk factor for encephalopathy and neurological disability that is understated and underevaluated at this time. The prevalence of bacterial, viral, protozoan infections during pregnancy that can cross the infection, cross the placenta, and have an adverse neurological effect on the developing fetus may be significantly underestimated. It appears that 3rd trimester maternal bleeding or trauma in pregnancy are rarely associated with neonatal encephalopathy, and intrauterine infection, placental insufficiency, associated IUGR, which we talked about before, and maybe neonatal hypoglycemia may be important contributors and warrant further investigation. In the first study, which was published in 2003, the ACOG Task Force on Neonatal Encephalopathy and Cerebral Palsy, they established 4 essential criteria required to define an acute intrapartum hypoxic event that's sufficient to cause cerebral palsy. And these 4 are listed here, which we've talked about some of them today. Basically, they focused on oxygen deprivation at the time of birth. This edition highlights significant advances in diagnosis and treatment, and it has determined that you need a broader perspective that may be more fruitful. And that the fact we need a broader perspective because we need to be sober in our recognition that we have significant knowledge gaps and we don't have definitive tests or set of markers that accurately identify with high sensitivity and specificity any infant whose neonatal encephalopathy is attributed to an acute intrapartum event. So if you have a baby with a depressed newborn APGAR score of 5 and less than 5 minutes, you want to be certain that you obtain the umbilical artery pH properly, as we've talked about. You want to be certain to submit the placenta for pathological evaluation. If your shop does not have somebody who's good at doing pathology evaluations of placenta, maybe send it out to another institution where they have a superior pathologist who's used to doing those examinations. You want to make sure that you review the fetal heart pattern on admission carefully within the first 30 minutes, and then compare it to the fetal heart in 30 minutes before the delivery, at the 30 minutes right before delivery to the initial admission, and see if there was a significant change. You may want to investigate Kleihauer, Betke, or tool, I've limited to just one part of the tool because in my original slides I had all three, but I think it's best if you look it up there, is a tool for recording in cases of a delivery of depressed newborn with an ACOG score of 5 or less than 5 minutes. And it goes into a thorough detail of all the data that we are suggesting be collected every time one of those babies meets that criteria. And I suggest that you look at the treatise to find that and use that in your institutions. So what we talked about today is that cooling before 6 hours is the standard of care. MRI, both early and late, are essential to the evaluation of the newborn with neonatal encephalopathy. Placental pathology should be performed in all cases of low ACOG scores. Accurate blood glasses are critical. And what we're looking for is not to just establish 4 criteria, but now we need to create a patchwork quilt of information for every baby that has neonatal encephalopathy. Remember that the MRI should be obtained on all term newborns with moderate or severe encephalopathy. The optimal acquisition and interpretation of MRI is critical. And despite the advances in neuroimaging, our ability to precisely time the occurrence of an HI event is still limited, estimating within days rather than hours or minutes. From epidemiological evidence, the absence of NE in an infant who later manifests cerebral palsy indicates that the cerebral palsy was not caused by the perinatal hypoxic ischemia. Thus, the pathway from intrapartum hypoxic ischemic injury to subsequent cerebral palsy must certainly progress through neonatal encephalopathy. So thank you very much.
Dr. Waldman, thank you so much. That was a whirlwind of information, and I'm very glad to be able to tell everyone that we will be posting it on the OB Consult website shortly after this so that people can still get a chance to look at it. But remember, for the group, you can ask questions by clicking on the orange box with the white arrow, I think located at the upper right-hand corner of your screen. And we'll answer as many questions as possible. I know we had a couple that had come in. One of them was, is it financially feasible to add MRIs to all newborn intensive care units? Are there any other options?
This is going to be a very important question for many of our neonatal intensive care units. The financial feasibleness of adding an MRI is obviously going to depend on the center and how many babies that center takes care of, and that's a careful question that can only be answered by the individual hospitals. But it's very clear that MRI is the only modality that's accurate, and that it needs to be done both early and late, and that you need neonatal neuroradiologists to be able to read those MRIs because the ultrasounds and the CTs are just not good enough. So I hope more and more of our major institutions will get MRIs in their labor and delivery units, in their neonatal intensive care units. I hope. We'll see.
Thank you. One other question. How significant is the decrease of neonatal seizures with electronic fetal monitoring versus intermittent auscultation?
This is an old study that actually was done in Greece where auscultation was balanced against fetal monitoring. What they didn't see was a decrease in stillbirth rate, which was a surprise, I think. But the problem with both seizures and stillbirth is the numbers are very small. It was statistically significant, but I really don't know how. I don't remember exactly how statistically significant it was. But it was clear that electronic fetal monitoring does help you decrease seizures.
Good, thank you. Well, let's see. I think that's about all that we have at this moment. I want to thank everybody for joining us. on this webinar. Please stay tuned. We will be having another webinar coming up in the next month or so, and you will get some information about that. And again, Dr. Waldman, thank you for taking the time to tackle this very important topic and very complex. I think you did a great job. Thank you, everybody, and have a great day.